Okay, now so let's talk about shoulder dislocation. I am going to mainly talk about it briefly. So, where will the shoulder dislocate mostly? What is the most common direction of dislocation? And why is this way? So, if we are looking at the shoulder to understand it, so we have here the humerus, which get inside the glenoid here. The glenoid head has throughout it, let's say, the labrum, and it has some ligaments. For example, here, which one is this one? Inferoglenohumeral ligament, the anterior part. So this humerus, which is here, and this glenoid with its labrum, tries to capture the humerus inside here and doesn't let it just dislocate. Now, if I'll do it a little bit more, maybe exaggerated, you can see that the most fragile part of the shoulder is the anterior part. The anterior part is the most fragile one. So this is where the shoulder will dislocate mostly, and about around more than 90% of the time, where will the shoulder dislocate? The dislocation will be an anterior dislocation. So this is the most common direction for dislocation, anterior shoulder dislocation. Mostly, what position the hand will be where the dislocation occurs mostly. How the person should be, in which position it is most common to dislocate shoulder. The answer is based on two positions. One is the external rotation of the shoulder, and the other is abduction of the shoulder. Combine those two, and you will figure out that it can be seen in many situations. This combination of external rotation and abduction of the shoulder is the most common cause of anterior shoulder dislocation. This is the position where the shoulder can dislocate. And where do you see this position? For example, if someone throws a ball, he can just do this position of his hand, use the ball, and this is exactly 90 degree of external rotation and 90 degree of abduction. This is the most common position to dislocate the shoulder anteriorly, and this is also called, if you put your patient in that position, it is also called the apprehension test, to test if the patient, or apprehension, I'm not sure, to test if the patient feels like he is going to dislocate, and if he feels that way, it tells us that the apprehension test is positive, namely the patient feels that he is going to dislocate, and this tells you that there is instability of the shoulder, usually from recurrent dislocations. So the shoulder is most probably will dislocate anteriorly, but what happens? Why after the first or second dislocation, recurrent dislocation is more common? Why the shoulder becomes not unstable after some dislocations? As you can see right over here, there are some structures that can be damaged. So here is the labrum here. So if we look it again and again, I'm looking on the humerus inside the labrum here in the glenoid, and when it is dislocated anteriorly, what can be done? What can happen? So this part, which is the glenoid and the labrum, can be damaged. So the anterior inferior part of the labrum is most commonly damaged, and this is called, what is the name for this? This is called a Bankart lesion. Now this lesion can involve the glenoid bone or just stretch and tear the labrum. If it involves the glenoid bone, and I make a very specific bold on the bone, so how would it be called? It will be called Bankard lesion, but which type? It will be called bony Bankard lesion, because there is also bone. And if the glenoid bone is not involved, so how would it be called? Glenoid not involved. So this is a tear only of the anterior inferior labrum. It will be called simply a Bankard lesion. Usually, when there is a Bankard lesion, when there is anterior dislocation, also the posterior part of the humerus get, for example, get something like compression fracture. And what's his name for this? The name is Hill-Sachs lesion. And this is also very, very common in anterior shoulder dislocation, Hill-Sachs lesions. So after anterior shoulder dislocation, we can look for Bankard lesion, namely anterior inferior labrum tears, that can also involve the glenoid bone, and it will be called therefore bony Bankard lesion, and also for the Hill-Sachs lesions in the posterior part. Now this tear in the labrum and the Hill-Sachs lesion, especially if it's a bony Bankard lesion, it can cause a weakness in the anterior inferior part, and the patient can dislocate again and again and again and again. So if there is instability and recurrent dislocations, there are treatment for this, like arthroscopic. Like how can we fix this problem? How can we fix this problem? If we have a labral tear, for example here, if you're looking at 3 dimensions, this is the labrum here, and here I have a tear. It's just gotten out. So what I can do is just fix it by suturing, so repairing the labral tear. But this is for labral tear. What can we do if there is also a bony lesion and part of the glenoid just went out? Here I have no glenoid left, it just went out. What can we do? In glenoid is gone. In the area, of course, not all the glenoid is gone. The anterior inferior glenoid is gone. What can we do? We are left with less bone. What can we do is just repair it with a reconstruction, like a graft. And we will take, where can we take this graft from? If you think about the shoulder, where is the very close place you can take a graft from? So the answer is the coracoid process. Anyway, you are taking a graft and you are fixing it with a bony graft. So it is called sometimes, for example, Latarjet procedure, or it is just procedure. So it is just a bony repair of the lesion. So you are repairing it with a bone which is left, which you are missing because of the glenoid fracture. So most commonly anterior dislocation. When you will encounter posterior shoulder dislocation, which are much less common, less than 10% of the time of shoulder dislocation you will encounter posterior shoulder dislocation. There is also inferior and etc., but anterior shoulder dislocation is the most common one. So what can bring you to a posterior shoulder dislocation? So a seizure is one of the options that can cause posterior shoulder dislocation. Anyway, when a patient, I won't talk too much about it, but when the patient can dislocates, there are ways to reduce the dislocation in the acute phase. All the tears repair that I talked about arthroscopically, like this one, all the bony repairs that I talk about this one, of course, they are not the acute treatment. The acute treatment of anterior shoulder dislocation is to reduce the shoulder, to reduce the humerus back into the glenoid. So there are some methods to do it, but some of them are based on external rotation and abduction, like what happens in the dislocation. Some of them are based on traction and contratraction, and I'm not going to get into the methods to redislocate the shoulder, but this is the idea in the acute phase. Now, not every time of the shoulder dislocation there is need for a surgery. You need to understand if the patient does have instability, and if he has recurrent shoulder dislocation. If he does have, you can consider it, but don't forget the conservative treatment with physiotherapy and everything else. So this is it. This was about anterior shoulder dislocation or shoulder dislocation, especially focus on the most common part and most common site or most common option for dislocation, which is the anterior shoulder dislocation. Thank you very much. If there are any mistakes or corrections, please tell me, and that's it.